Thank you, Andy. So hello and welcome, everyone. This is Caleb from TASC at the National Rural Health Resource Center. Today we have Lindsay Corcoran from Stroudwater and Associates, a senior associate from Stroudwater and Associates, to talk to us about COPD finance. I don't have a lot of preamble to that, just we will have some polling questions beforehand to make sure we are providing the best webinar and education as possible to help us improve our content. A reminder to flex coordinators and hospital CEOs and hospital people who've received the email, we have a COPD assessment that we would like to have as many people as possible complete. We've got a great response on that so far. We're really pleased with the amount of responses. The deadline, we will close that assessment at the end of the week on the 21st. So if you've not had an opportunity to send out a reminder to your hospitals, we definitely appreciate your assistance with that. Another reminder, we have a handful of COPD podcasts to help raise awareness and kind of complete the story of COPD provided COPD care in rural America. We have a provider participating in the podcast series, Grace Ann Koppel, who's head of the COPD Foundation and a great advocate for COPD care in rural America. Paul Moore, representative from the Federal Office of Rural Health Policy, as well as a respiratory therapist, Michelle Collins from Maine, whose episode will be released later this week. So if you've not had an opportunity, please check out our website at ruralcenter.org to take a moment and have a listen to those podcasts. I really appreciate the work that we've been doing on those. Short of that, I thank you for taking a moment to complete the polling questions. All phone lines are muted as a way to help provide clear audio recording, and there will be plenty of time at the end to ask questions, and we'll get those phone lines unmuted at the end of the podcast. In the meantime, please utilize the chat box to the left. Jill has found it already, so please utilize that to make sure we capture all questions that you have, and we'll make sure there's time at the end to go through those. Short of that, thank you guys for taking the time to join us today. And Lindsay, I think we are ready for you.
Great, thanks, Caleb. Caleb, can you hear me?
I can, yes, thank you.
Okay, great. Well, thanks everyone for joining this webinar on finance as it relates to COPD. Really today we're going to talk about, just COPD in general, and in addition to that, pulmonary rehab as really a best practice treatment option, given and provide some information so you as State Office of Rural Health directors and flex coordinators can really have an understanding to support your state's rural hospitals who may be interested in pursuing a pulmonary rehab program to support the needs of the COPD community that may be present. So with that said, today we're going to, talk about some current statistics as it relates to COPD, in addition to incorporating some of the more rural relevant statistics as it relates to COPD. Talk about treatment options, the value proposition for rural hospitals as it relates to potentially implementing a pulmonary rehab program, and then more specifically about pulmonary rehab programs, their conditions of participation, which is the Medicare requirement, and some high-level billing and coding information. If hospitals are already deploy a pulmonary rehab program, we have some insight on how to maybe expand that current program, or even what we need to do to develop a pulmonary rehab program. In addition, we'll talk a little bit about care management and some resources that may be available for hospitals or state offices to go out and seek additional information. So really, COPD in America. So COPD is chronic obstructive pulmonary disease. It's a common and preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation. COPD was the third leading cause of death in the U.S. in 2015, and it's dropped to the fourth leading cause of death in 2016. There's a significantly high prevalence of COPD in the U.S. About 15.5 million adults were diagnosed in 2015. To put that into perspective, that's about 6% of the U.S. Adult population in 2015 diagnosed with COPD over 1 year. So definitely a high rate prevalence there. Of that 15.5 million adults, 350,000 Medicare patients were hospitalized, and approximately 150,000 deaths occurred as a result of COPD. And really, you know, what it comes down to is COPD is costly. More than $32 billion was spent on COPD-related patient care in 2010, and that is projected to increase to about $49 billion by 2020. So that's a 53% increase in 10 years on spending as it relates to COPD patient care. You know, so given the severity and the overall cost of the disease and the burden it puts on patients, you know, a call to action is definitely needed as it relates to COPD, so we can, you know, start to change the perception, the treatment, and the long-term care of COPD. When looking at COPD in rural America, the prevalence rate for COPD is about 12% of individuals living in rural communities, compared to 7% across the U.S. When adjusting for age, the prevalence in rural areas is about 8.2% compared to more urban areas, which is around 4.7%. So, you know, you ask yourself, you know, why is there such a divide between rural prevalence and more urban population prevalence? We've seen, and studies have shown, that rural populations have a greater risk exposure to factors that are associated with COPD, one being tobacco exposure, so smoking. It's been known that tobacco accounts for about 80% of all cases of COPD. So definitely a high amount of association of tobacco with COPD. Respiratory infections are also a risk factor or an exposure, and occupational environmental exposures. Around 1 in 5 cases of COPD are attributed to occupational exposures, so whether it be inhalation of various materials, you know, in the working environment, air pollution, that sort of thing, as well as genetics also plays a role in the divide between rural and urban. Rural areas tend to have higher proportions of socioeconomic residents. And moving to the next slide. In addition to, there's that limited access to appropriate healthcare services, which we know is a significant disadvantage for rural populations. One being the access to smoking cessation programs, in addition to specialty care. You know, specialists being that are really associated with COPD and pulmonary rehab is the specialist of pulmonologists. And out of around 12,000 self-identified pulmonologists in the U.S., about 92% were located in urban areas, only compared to rural areas where about 2% were located in rural areas. So, you know, that just aids in supports that there's still a wide disparity in access to specialty care between urban and rural areas. In addition to some of the other divides is really the barriers to access to service, and some of those being transportation, geographic accessibility. Studies have shown that patients who live in rural areas had to drive an average of 33 and a half miles, spending more than 42 minutes to receive pulmonary care services. So definitely, we're having to travel longer distances to access some of these healthcare services. Then we have a higher percentage of uninsured or underinsured patient population in our rural settings, as well as a cultural perception where patients may be kind of embarrassed or not really want to speak about maybe some of their symptoms. Studies have shown that in about 27% of adults reported that they had not spoken to their physician about COPD symptoms. So definitely there's some cultural perception there that really is happening within our rural communities around COPD. Some of the treatment options that have been our best practices as it relates to COPD is first really smoking cessation. I gave you the statistic about the smoking as it relates, or tobacco use as it relates to high prevalence of COPD. Smoking cessation has the greatest capacity to influence the progression of COPD. So if effective resources and time are dedicated to smoking cessation for patients, then there's a higher quit success rate for patients that are tobacco users that can be achieved. Vaccinations, typically influenza and the pneumococcal vaccination, will decrease and lower respiratory infections that are associated with COPD. Pharmacological therapy, so medications can reduce COPD symptoms, frequency, and severity of exacerbations. And rehab, education, and self-management. And we'll talk obviously more about the rehab component of this treatment, but really rehab, education, and self-management improves symptoms, quality of life, and physical and emotional participation in everyday activities. Another treatment option is oxygen therapy and ventilator support. These both can be supportive in survival rates of patients with chronic or advanced stages of the disease. And then lastly, surgical interventions. And these are certainly for select patients, but they would include, lung transplants or lung volume reduction surgical procedures. So those may be an option for patients, select patient population. So at a high level, what is pulmonary rehab? And pulmonary rehab is a supervised exercise training, health education, and breathing technique program for patients that have certain lung conditions, one of them being COPD or different lung problems. Sometimes patients with asthma or emphysema will participate in pulmonary rehab. The overall goal is really to improve the physical and psychological condition of patients with some type of chronic respiratory disease. And the benefits there's certainly a long list of benefits for the patient. Obviously, improved survival is a huge benefit and a goal of pulmonary rehab. Exercise tolerance, increasing the ability to walk further and to participate in really activities of daily living. Lessened perception of breathlessness, so shortness of breath. Improved quality of life. Reducing hospitalization and time, as well as the number of hospitalizations per year, and decreased anxiety and depression, arm function, and improved respiratory muscles. So, a pretty long list of benefits as it relates to pulmonary rehab, and we'll go into detail on some of those in a minute. So looking at pulmonary rehab in rural settings, there's definitely a divide as we know it. There's about 1,300 U.S. counties have at least one hospital outpatient pulmonary rehab program, while 17 counties do not even have a pulmonary rehab program, including 697 counties that don't even have a hospital. Looking at the number of critical access hospitals, about 36% critical access hospitals and about 47% of rural PPS hospitals do have an outpatient pulmonary rehab program. But there is, certainly a divide, even though that there's quite a bit of evidence that supports the benefits of pulmonary rehab programs. Certainly there is a shortage that exists in rural areas, given the high prevalence rate of COPD in rural America. If you take a look at the map, which is the percent of hospitals with outpatient pulmonary rehab by state, you can see that there's a higher percentage of hospitals in the Northeast and the Midwest that have pulmonary rehab programs relative to the South and the West. So given high disease prevalence, and especially in rural communities, the focus is really important for rural hospitals to become more aware of pulmonary rehab and really consider supporting the needs of their COPD community by implementing perhaps the pulmonary rehab program. So what's the value proposition? What's in it for implementing a pulmonary rehab program? How is that going to benefit the hospital? First, it's the overall improvement of health and education. That at the end of the day, hospitals, are there to care for their patients and provide health, improved health and improved education for patients to get better. And so there's obviously that. In addition to decreased admissions and readmissions, and we'll look more at readmissions as it relates to COPD, but there is definitely a significant high rate of readmissions for hospitals with patients with COPD. So, and also that leads to increase in ED visits. So with adding a pulmonary rehab program, you're supporting those patients that may be frequent users of our emergency department or frequently are getting readmitted for an exacerbation of their COPD. So, we're gonna be able to help that population. Out-migration. So, typically what we're seeing at rural hospitals is, patients are going to travel. They're going to have to travel for specialty care if it's not offered locally. And typically when you lose a patient to a specialist in a more urban setting, they tend to continue to use that hospital that's elsewhere a little bit more. And it's hard to get that patient back. So if we're able to provide some services that support, definitely a need in our community, then we're less likely to have that out-migration happening, where the patient then starts to utilize services for, other specialty services at that urban hospital. It's an additional service offering to support our patient needs. So again, just if we have a high prevalence of COPD within our community, this is an additional service offering to support those patient needs, as well as value-based healthcare. We're moving to more of a value-based healthcare system, and with a goal to provide high quality and low-cost patient care, and we'll be able to do that with pulmonary rehab and meet those needs. So jumping a little bit more into the specifics of pulmonary rehab, looking at the Medicare conditions of participation, and which outlines the mandatory components of pulmonary rehab. So if you are a hospital and you're going to be billing for pulmonary rehab, these are the must-haves to bill Medicare. And we'll go over, there's 5 mandatory components, and I'll go over at a high level each one of these. The first one being a physician-prescribed exercise program. So typically that would include, exercise conditioning, breathing, step and strengthening exercises. There has to be some type of aerobic exercise included in each pulmonary rehab session. So, and this must be prescribed by a physician. So when a physician prescribes this exercise program, they need to indicate what the mode of exercise is, which is typically, aerobic exercise, what the target intensity is. So what's the, for example, what's the predicted heart rate of a patient, duration of each session. So they're going to come, for each session is going to be about 20 minutes. What's the frequency? So what are the number of sessions per week? So maybe they want their patient to come 2 times a week for a pulmonary rehab, or what's the progression? What's it going to take to progress the patient? And this prescription must be appropriate for the individual patient. So you can't have, one prescription for every single patient and it's the same. It needs to be very individualized for the patient. Your pulmonary rehab program must include education or training. And so education would include, information on respiratory problems, management, and appropriate, this would be needing some smoking cessation counseling. This also, any education that is prescribed must be documented in the individual's treatment plan, and so we'll go over what an individual treatment plan also includes. In addition, we have a psychosocial assessment. This is really an assessment or an evaluation of a patient's mental and emotional function as it relates to their respiratory condition or their COPD. There needs to be a periodic reevaluation done of a patient, and that's to really ensure that the patient needs are being met and the individual's response to and the rate of progress under the treatment plan that's been laid out for them. And you can use a assessment tool like a depression screening tool, but it cannot be used separately without a plan, and it must be it must be included in the physician's individual treatment plan for the patient. Then we have an outcomes assessment that needs to be done. Again, that's another written evaluation of a patient's progress as it relates to their pulmonary rehab. And we want to make sure that, that the patient is showing some type of progress as they go through their rehab. So if, for example, if the goal was for a patient was to be able to walk for 30 minutes on a treadmill at 2 miles per hour, without shortness of breath, and the goal was either met or not met. If the goal was met, then it would be necessary to include what modifications were made, or if they were not met, it would be necessary to include modifications to the care plan to address that failure of not meeting that walking goal. So that would be the outcomes assessment. And then we have the individualized treatment plan. This is actually the most important component of a pulmonary rehab program according to Medicare. This is a plan that must be established, reviewed, and signed by a physician who's involved in the patient care, and it must be updated and revised and reviewed again every 30 days that the patient is in treatment. Who signs and who develops the individualized treatment plan? It can be a referring physician, so typically, a primary care physician or the pulmonary rehab medical director. But the pulmonary rehab medical director or a supervising physician must review and sign the plan prior to a patient starting any treatment. So regardless if a primary care provider writes the treatment plan, we need to have the medical director or the supervising physician review and sign the plan prior to the treatment. Some of the components of an individualized treatment plan include description of the patient diagnosis, the exercise prescription, so the type of exercise, the amount of exercise, the frequency and the duration, goals set for the patient, and that the mental and emotional functioning, which is that psychosocial assessment, and then the outcome assessment, which is that evaluation of progress as it relates to an individual's rehab and effectiveness of the pulmonary rehab program. So according to Medicare, those are the 5 components of a pulmonary rehab program that must be met in order to bill for Medicare for these services. So to bill for Medicare, some high-level billing and coding is pulmonary rehab are now a bundled payment, or it's bundled into a single HCPC, which is G0424, which is described as pulmonary rehabilitation, including aerobic exercise, includes monitoring per session per day. So patients are allowed a maximum of 2 one-hour sessions per day. 1 session of pulmonary rehab services a day must be 31 minutes. So in other words, and then if 2 sessions can be billed if pulmonary rehab lasts at least 91 minutes. So they can have a maximum of 2 sessions per day if we meet that at least 91 minutes of pulmonary rehab. So I have some examples to help make that a little bit more clear. If a patient were to receive 20 minutes of pulmonary rehab services in a day, then no pulmonary rehab we would not be able to bill for pulmonary rehab because it was less than 31 minutes. But if a patient receives 20 minutes of pulmonary rehab in the morning, 35 minutes in the afternoon, in one single day, you would only report 1 session of pulmonary rehab because the total of that 20 minutes and the 35 minutes would equal 55 minutes, and that does not get you to the 91 minutes to be able to bill for 2 sessions. And then the last example is if a patient receives 70 minutes of rehab in the morning and 25 minutes in the afternoon, you'd be able to bill for 2 sessions because the combined service during that day and the total time was about 95 minutes, which exceeds that 91 minutes. So, that really goes back to the importance of when we do have a pulmonary rehab program, we need to make sure that we are capturing time and billing appropriately, because if we're not meeting these time limits, we're not going to be able to capture, the highest amount of revenue for these services. So some limitations on coverage for Medicare. Medicare Part B pays for the pulmonary rehab program, and again, it's 2 one-hour sessions per day, and it's up to 36 lifetime sessions. So if you're so that equates to about 72 sessions a year, because you can have 2 sessions in one day. When we're looking at some of the commercial coverages, there's definitely insurance that are out there that are commercial insurances that are following Medicare guidelines. But, for instance, Blue Cross Blue Shield of Kansas has 18 sessions in a single 6-week period. So they've shortened that limitation of coverage, and so you'll have to check with your insurance carriers what is covered and what's not, and where there may be some limitations. So in order to meet the requirements of pulmonary rehab, a patient must meet what is known as a GOLD stage. And GOLD stands for Global Initiative for Chronic Obstructive Lung Disease. And you can see the scale below. Patients who are eligible for pulmonary rehab must be in a stage 2 to 4 to be covered. And some common diagnosis, ICD-10 codes for COPD include that list on the right-hand side. So these Medicare refers to these GOLD stages and will deny claims if a patient does not meet this GOLD standard. A lot of the COPD diagnoses are for, bronchitis and emphysema are typically the two main diagnoses. And so, the question, is, well, what if a patient does not meet the COPD criteria in that GOLD standard? Well, there certainly is hospitals that can provide respiratory care services and meet the needs of those patients that may not be diagnosed with actual COPD. And those are listed here where we can bill for therapeutic procedures which increase strength and endurance, example being breathing retraining or muscle training. And then we have improve respiratory function. This is teaching patients to perform tasks with less respiratory effort. And then there's also a group exercise respiratory care service that a hospital can provide. And again, it's to improve respiratory function, but this is on a group level, so includes 2 or more individuals. So there's some other, if a patient does not meet pulmonary rehab program status, then there are some additional options that we can be providing for these patients. So, if a hospital is considering the development of a program, here are some bullets that we would want to ask and want to investigate as a hospital that's kind of looking to develop a pulmonary rehab. One being, obviously, identifying the current and future need. So looking at, what's the disease prevalence in our community? How does this COPD affect our hospital? And where's the future as it relates to COPD and the prevalence there? Looking at investment and resource needs. So is there space that is needed or capital investments? What is the staff that's required and the equipment may be needed to support a pulmonary rehab program here at our hospital? And is there an opportunity to share resources, maybe with another department? We've seen, hospitals offering cardiac rehab, and then a lot of times that the same equipment and the same space could be used for pulmonary rehab, or, if you have a rehab facility and where you're offering PT and OT, that space could also be utilized for pulmonary rehab as well. So, looking at what the resource needs are and the level of investment in terms of capital and staff. What are some of the clinical and regulatory requirements? We'll go over some of the resources that are out there that help, hospitals implement a pulmonary rehab program, and provide really up-to-date requirements to either whether it's a bill for certain services or to provide, some clinical change and anything that is changed on the clinical side. We want to look at partnership opportunities, whether maybe we are a hospital that's part of a system that we can, partner with our system and offer this to our hospitals or to our rural hospitals, partnerships with providers and even payers. There may be opportunities that this can be further supported by those partnerships and that outreach. And then we need to make sure that we have a pricing strategy as it relates to our program, and then really looking at the value of reducing readmissions. And we can easily look at that. Hospitals are having to track their COPD readmissions, and we can make sure that we are, reducing those, and we can, figure out what that dollar amount is if we are able to reduce that readmission and potentially that penalty rate if we have a high readmission rate. If we're looking to really expand or grow, if we our current pulmonary rehab program, some ideas around that is really marketing, promotion of services. I tend to find that rural hospitals, they're almost their best kept secret, and they haven't done a great job of really promoting themselves, whether it's to their own community, to the providers that support them within their own community. I think there's definitely opportunities within rural hospitals to do a better job about promoting and marketing their services. And you don't really have to have a dedicated, marketing director that's going to go out and do all this stuff for you. Getting staff or, managers of departments, and promoting and having them promote the services are certainly an asset to an organization. Providing, education to support the growth of our pulmonary rehab program. So whether it's educating the providers that are making referrals, providers that aren't making referrals, but certainly could be making referrals to our pulmonary rehab program. There's opportunities certainly to provide any type of education to those areas. Expanding the role of respiratory therapists. We've seen that there's been some movement on how we utilize respiratory therapists. Typically, it's always just been in the hospital setting, but expanding their role to more of a clinical setting and out in the clinics where they can, support the primary care providers in that education, as well as helping to, diagnose potential COPD patients and having that expertise on what pulmonary rehab includes and if a patient can be supported by that program. Hospitals can also look at developing patient support groups. There's been studies that have shown the benefits of having patient support groups. So a COPD patient support group could be beneficial for your hospital and to really help provide education and self-management education within those groups. And then maintenance programs. So again, maintenance programs are for patients that have finished and gone through a pulmonary rehab program. A hospital can offer a maintenance program to those patients, and it would just be continued exercise. Patients would have to pay, out of their own pocket, but it's the benefit of continuing exercise after a patient has completed the pulmonary rehab program. The benefits certainly outweigh any, stopping any type of exercise program after your rehab program. And then in addition, it's care management. We'll talk about that in a little bit, but care management is an additional opportunity that hospitals can start providing for their patients and obtain some additional revenue if we bill and code correctly for that service. And we'll talk about that in a minute. So care management, and we're here now. So, I think care management plays a huge role for rural hospitals because of readmissions. Studies have shown that patients hospitalized after acute exacerbation of COPD have a 30-day readmission rate of 19.2%. Hospitals are penalized for that 30-day readmission. And so there's some care management strategies that hospitals can implement to help reduce those hospital readmissions. So the first one being transitional care management. These are services designed to help prevent hospital readmissions. So providing seamless care from when a patient is discharged from a hospital and their care has been transitioned to, a clinic or a community-based care setting. These are providers, they can conduct transitional care at discharge in up to 30 days. So some of the components that you need to include in that transitional care management is interactive contact within 2 business days of discharge of a patient. There are certain non-face-to-face services that you can bill for, where a face-to-face service may be reviewing discharge information, interacting with other providers about that certain patient, providing education, and establishing referrals. And then there has to be a face-to-face visit within 7 to 14 calendar days of discharge, and that can be provided via telehealth. You must also establish medical decision-making and medication reconciliation on or before the face-to-face visit. So there's 2 different CPT codes that are associated with transitional care management, and these are from the Medicare fee schedule. Rural health clinics, if they are providing the services, they have a different billing code, but these are the average payment for these services here. The 99495 is for the moderate complexity, and so it's the 14-day follow-up after discharge, and the 99496 is for patients that have a higher complexity, and that follow-up is done within the 7 days. Then we also have chronic care management, and again, this is another component of care management which can help with support of your COPD patients within your community, as well as helping to reduce some of those readmissions. Chronic care management is for patients or Medicare beneficiaries that have more than one chronic condition, and COPD does qualify for a chronic condition. Patients are to have at least 20 minutes of clinical staff time, and that is directed by a physician or a qualified healthcare professional. And we can bill for services that are either moderate or complex, and the services include, utilizing the EHR to record a patient health information. You have to develop a comprehensive care plan, which is really the assessment of patients' medical need, their functional needs, and their psychosocial needs, and really develop a plan based on those needs. There needs to be access to care and care continuity, which needs to be available 24/7. I have hospitals that are saying, well, 24/7, but our doctors only work 9 to 5. How can that, how can we provide that service? A way to do that is electronically, is a way that we can provide access 24/7 for our patients to meet this care management need. A patient portal is one of them, and then if you have electronic appointment scheduling for patients, that's another way to meet that access to care 24/7. And then we have to develop a comprehensive care management, and that care management is, making sure that our patient receives preventative care services, that the medication is reconciled. We've provided education on self-management, and then, care coordination of our patients. And then transitional care management also plays a role in chronic care management, and that's really providers needing to manage the care between different providers in different care settings. So again, the 2 CPT codes that we can bill for chronic care management is a 99490 and a 99487. And one is, at least 20 minutes of clinical staff time, and the other one is up to 60 minutes of clinical staff time. Oh, I did not advance that slide. I apologize. So some of the resources that are out there that are available to hospitals, as well as, flex coordinators and state offices of rural health that I have found beneficial, as well as I know that a lot of hospitals turn to these organizations. Of course, for anything related to billing and coding, CMS provides pretty updated information, as well as, looking at the local level to your max, where they may have some differences in how things are billed and coded. Professional organizations provide a great source of information. You can find evidence-based clinical best practices, regulatory updates, and continued education. Some of the professional associations that we've looked to is the American Association of Cardiovascular and Pulmonary Rehab, American Association of Respiratory Care, American Thoracic Society, and the COPD Foundation. As it relates to continued education, I know like the American Association of Respiratory Care has come out with a pulmonary rehab certification for respiratory therapists. So those type of opportunities do exist through some of these professional associations. So you'll have to just make sure that you're continuing to seek out some of that information and sign up for listservs and mailings, and so that will help provide some updated information as well. Lastly, in terms of resources, I think internal expertise is huge. If you do employ respiratory therapists, they may be members of some of these professional associations, and so they may be able to provide you with some insights. And so looking internally at our own hospitals could provide some real great resource opportunities for whether it's hospital leadership or department managers. And really, in conclusion, if we have hospitals that are looking to develop a pulmonary rehab program, we ask, do your homework. Don't just go out and say, oh, we're going to do this and not have a plan. Any type of service line development needs to have a plan before you go out and jump into this. In addition to doing your homework, reaching out to peer hospitals that are actually, already have a successful pulmonary rehab program. I'm a firm believer of, connecting and sharing best practices. And I think, if someone is doing something great, why not, be able to get some insight and some firsthand information about what works and what doesn't from some of your peers. And then just a note about funding. I mean, we hear this a lot, that pulmonary rehab just, the reimbursement is so low, we can't cover our costs. And that's why a lot of hospitals will defer investing in a pulmonary rehab program. But I do think that with the the continued focus and the intensity of the focus that has recently been done as it relates to pulmonary rehab and COPD in general. I think we're going to make some movement in terms of hopefully finding additional funding to support these programs. If not, we're going to continue to have that growing proportion between rural and urban access to COPD services. And the number of COPD patients within our rural communities is going to continue to grow. So hopefully this presentation was able to answer a few of your questions that you may have as it relates to COPD and what's needed to establish a pulmonary rehab program at a high level. But that is all I have. So I appreciate your time.
Great, thank you very much, Lindsay. So we've got about 10 minutes left in our scheduled webinar time. If anyone has any questions, I didn't notice any coming in through the chat box, but *2 will unmute your line if you'd like to ask Lindsay. In the meantime, we will thank you, Andy, for remembering the exit polling questions. We've got a couple things, and then there's one spot where we ask for additional resources that might be helpful. And of note, one of the recommendations toward the end of the webinar presentation, Lindsay, you referenced the call a friend, phone a friend that has a successful pulmonary rehab program, and that's one of the efforts of the assessment that I referenced earlier, is to gather information that we might be able to share with other hospitals and flex programs to share with others, that they might be able to do some research or start a program should that be the correct path, or at least understand what resources and support they need along the way. So thank you again, those who have completed the assessment and those who have sent out that to their hospitals. Joanne, I see that your hand is raised. *2 will unmute your line, or please feel free to type your question in the chat box.
And Caleb, just to add to what you were just saying about, reaching out to peers, the American Association of Cardiovascular and Pulmonary Rehab actually is an organization that certifies hospitals in their pulmonary rehab program. They list the hospitals that are certified. So if you don't know of one that may be local to you, you can go on their website and look for the hospitals that are that do have certified programs, and maybe that's a way to reach out to them.
Absolutely, thank you. And thank you guys for taking the time to complete these polling questions. We definitely utilize these to ensure that we're providing beneficial content. And if you have any resources that you know of that would be helpful, please go ahead and type those in there. This webinar, as well as the other COPD resources that we are creating here at the center, will all be posted to our website at ruralcenter.org. And Joanne, thank you for typing in your question. What strategies are rehabs using to acquire physician signatures on ITPs prior to exercise?
Yep, that's a great question. So for programs that are, so a patient is going to come to a typically maybe a group pulmonary rehab exercise, and a lot of times those are scheduled prior to, and I think just having that open line of communication with our physician And so making it mandatory that the physician review the care treatment plans prior to any exercise. So if we know when our established rehab program is going to be held, we make sure that that's communicated with our physician to obtain those signatures prior to that. So you cannot have a patient go through any type of exercise until that signature is obtained. So really, open communication.
Thank you. Any further questions, comments? *2 will unmute your line. All right. Well, I do appreciate everyone's time, and Lindsay, thank you very much for the presentation. A couple reminders, please send the COPD assessment to your hospital administrators or pulmonary rehab centers if you know who those people are. We have a number of COPD podcasts, one of which will be released. A new episode will be released this week with Michelle Collins, a respiratory therapist from Maine. And one of the additional resources that we're working on is a COPD manual directed toward flex coordinators in critical access hospitals to answer some of these questions, provide resources and a little guidance as examination of whether or not to start a program and how to do that, what information and resources are needed and available for that. And the expected outcome of that is August. So please reach out if you have any questions. I will type in my email address if you have any questions. And again, I thank you all for your time. Any last questions? *2 will unmute your line, or please feel free to utilize the chat feature.